You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Silvio Inzucchi, professor of medicine, the Yale School of Medicine, where he serves as clinical chief of endocrinology and medical director of the Yale Diabetes Center at Yale New Haven Hospital, New Haven, Connecticut. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape in Discussion. I'm Dr. Silvio Inzucchi, and today we'll be talking about treating type 2 diabetes in minority populations. This is a critical area for improvement in health outcomes across the United States. First, let me introduce one of the most qualified people I know of to speak on this topic. He is Dr. Enrique Caballero, and he's been committed to working with underserved populations for many years. He actually founded and directed for many years the Latino Diabetes Initiative at the Joslin Diabetes Center in Boston, and is now director of Latino Diabetes Health at the Brigham and Women's Hospital, also in Boston. Enrique is associate professor of medicine and director of diabetes education at Harvard Medical School, and is also now the chair of the Healthcare Disparities Committee at the American Diabetes Association. His steadfast work in this area and other areas as well has improved the lives of thousands of individuals with type 2 diabetes, and we're so fortunate to have Dr. Caballero with us today. Welcome, Enrique.
Hi, Silvio. Thank you very much for inviting me. Always excited to share this information. Hopefully that will be important for our audience today.
So before we get into our main discussion, can you tell me a little bit about why you became interested in diabetes and specifically diabetes management in minority groups?
Well, Silvio, as you know, I'm originally from Mexico. I was born and raised there. So I can say that I obviously belong to one of these racial ethnic minorities in the United States. And I think that allowed me to be probably a little bit more receptive and interested in understanding some of the challenges in the populations. But I also identified early on in my career when I came here to the United States that there are three facts that continue to be absolutely true. Number one is that racial ethnic minorities continue to grow very rapidly in the country. And it is in fact predicted that not that long from now, in the year 2030, about 40% of the population will be comprised by racial ethnic minorities. Point number two is that, and we'll talk about that in a minute in more detail, is that diabetes, particularly type 2 and its complications, are more common in these populations. And number three is that unfortunately, the quality of care that is provided to this population is not the same. So I think there's a lot of work to be done. And I think that's really one of the reasons why I became so interested in that, seeing how we could identify the problems and, of course, try to identify some solutions.
Well, let's talk about some of the compelling statistics regarding type 2 diabetes in minority populations, specifically in the United States, both prevalence, complications, and also, as you've already opened the door on, the quality of care that we provide to these patients.
Some of the most recent data show, based on the National Health and Nutrition Examination Survey, that the prevalence of diabetes in the white population is about 12%. It's about 19% in Asians, 20% in Blacks, and about 22% in Hispanics. So this is consistent with that concept that we've had for a long time, that is twice as common in minority populations when compared to the non-Hispanic white group. Incidence rates have actually declined over time, as you well know, but this has not been seen in minority populations. That decline has been seen mostly in the white community. Now, the prevalence of prediabetes, gestational diabetes, diabetes in youth, is also higher when we look at all these statistics. It is less likely for patients in racial ethnic minorities to achieve treatment targets. So for example, when we talk about A1C, blood pressure, cholesterol, and non-smoking, some of the major goals that we have with our patients with diabetes, statistics show, according to the enhanced data, that it is about 25% of people in the white community that achieve these targets. When we look at racial ethnic minorities, it's about 1 in 7. So it's almost a 50%, lower chance of achieving targets in these communities. Obviously, the disease and complications and many different outcomes are very different in these populations.
Let's get into a discussion of the underpinnings of some of these differences. Is this simply related to access to care? Are there pathophysiological differences? Are there cultural differences?
Over the years, what we have been able to identify is that certainly there may be some biological differences in some of these populations. But I would say that the more I am working in this field, the more I am convinced that it's really not the biological elements that determine all this. But if we talk about biological differences, I think it is important to remember a few things that have been demonstrated over the years. So for example, insulin resistance, which is of course important for the development of type 2 diabetes, has been demonstrated to be more common, more frequent in some of these populations, in the Hispanic Latino community, in African Americans, in the Asian community for sure. In Asians, it is more likely to develop type 2 diabetes at lower body weight, at BMI levels in comparison to the white community, for example. And that has actually led to also the concept that we all should screen for type 2 diabetes in Asians with a BMI above 23 and not 25 as recommended for other populations. So there are some of these challenges that we see from the obesity perspective, the insulin resistance perspective. Now, no one would develop type 2 diabetes unless there is also beta cell dysfunction. And there are some studies that show that, in fact, in some of these populations, it is easier for the beta cells to get fatigued. That's the reason why perhaps we also see younger individuals in these communities that develop type 2 diabetes. And I think that applies to Asians, Latinos, Hispanics, and the African American community. You may also remember, and the audience may also remember that there's this ketosis-prone diabetes that was described in New York some years ago. And these are patients, mostly from the Black community, who may present to us with ketoacidosis. And then we may think, oh, they have type 1 diabetes. Well, they don't. They actually have type 2 diabetes, but they develop acute insulin deficiency that later on gets better. But, it's interesting to see how some of these differences in biology may play a role. So yes, there are some biological differences, but for the most part, I think is all the other aspects that play a role here. So it's social determinants of health. These are the elements that lead to the development of type 2 diabetes and its complications in a direct way. Why do I say that? Because it's really the environment where people live that determines their lifestyle. So if people don't have access to the right foods, if people don't have the ability to exercise as it is recommended for the general population, then of course that's a challenge. If people don't have access to goods, services in the same way that other people do, of course that will impact their lifestyle. And so I think there are elements that really play a role here that I would say in general, we don't pay too much attention to in clinical practice. So to sum up, Silvio, maybe what I could say is I always think about the triad that explains basically all problems in healthcare. One is the healthcare system. Second is the patient, and third is the healthcare provider. But in the healthcare system, based on what I just said, I don't think that we are well prepared to provide care to minority patients because we don't have the structure for it. Our healthcare system, I have to say, it's really more reactive than proactive. It is really illness driven and not health driven. So we solve acute problems in patients. We don't pay attention to what is needed in terms of the chronic care model that may be more appropriate. There's not enough culturally oriented programs. And I don't think that we sometimes have the teams that can work with us in providing appropriate care to our populations. And then on the healthcare professional side, I think that we are probably not used to assessing these other factors easily. So if we think about, okay, how do I assess social determinants of health? I mean, that's not something that I will be able to modify. I prefer to be in my comfort zone of just doing what I was trained to do in medical school and in my area of work. And that's really to pay more attention to the pathophysiology and treatments.
And the numbers, right? The insulin dose and things like that. So you're talking about the healthcare provider. How can we be more sensitive, or shall we say culturally appropriate, when we're dealing with patients from minority groups? I mean, what do we need to understand about these social determinants of health?
Right. Well, I think that the first thing is to abandon the status quo, right? We know that what we're doing now, based on everything that I said earlier, is not working. the reality is that these patients are not achieving targets. And the easiest answer would be, okay, well, it's not my fault. I tell them what to do. They just don't do it. It's not something that I can modify. That's the wrong approach, Silvio. I think that we have an opportunity here to think outside the box and say, what is it that I am not doing that is impacting these outcomes? And that really takes courage and responsibility. And I think that calls for addressing some of these aspects in more detail in clinical practice. I know what people may be thinking. Come on, I'm so busy doing what I do already, and now you're asking me to do more than that? How am I going to do it? I don't have the time. I don't have the tools. I don't have the resources. I think that there may be an opportunity to create teams to really do this more proactively in clinical practice. I take one of these aspects at a time, and I try to address those with my patients, not in the same visit, because that would be impossible. So maybe one day we talk only about food, and is there food insecurity, for example? Can people really access the foods that we're recommending them? And if not, why not? Maybe I can refer them to a community-based program that can provide some of that help. Now, that's not something, again, that we routinely do, but I think that that's one thing that we should address. Exercise. Are people able to follow the recommendations that I'm making? And if not, is there a way for me to help them with that? Medications, of course. Can they afford the medications? People try to save money in many different ways. And again, I don't want to create a stereotype here, Silvio, because it's not just minority patients that are affected. It could be honestly anyone. So, but those are things that we need to pay attention to. And I don't think that we do that routinely. It's about integrating a more comprehensive approach to diabetes care by paying attention to all these different factors, what I think would get us to a different level.
So from your vast experience, particularly with the Latino community, any tips you might provide to us in terms of counseling patients about diet and lifestyle changes?
The first thing to say, because a lot of people have asked me over the years, can you recommend me a Latino diet that could work for my patients? And what I say is, well, really, there's no Latino diet. As a Latino myself, I have to say that I learned almost every week about something different from different groups in Latin America and some of my patients. So there's nothing that is uniform. Now people think about, okay, everybody eats rice and beans and that's the problem. I don't think that's the issue. I think it is about how people prepare food, still a lot of fried foods and a lot of carbs in many of the meals. And it's obviously the amounts as well. So I think that the best way is to get closer to patients, and rather than imposing a diet, is about understanding their preferences and work with them, preserving the culture, their culture, and then trying to come up with some recommendations that make sense. Trying to ask people to abandon completely what they do is never going to work well. And similarly, in terms of physical activity, the same thing. So for example, I created with my patients a salsa dancing program because everybody likes to dance. And that's getting closer to the culture, also about identifying activities that people like to do and not really to impose guidelines and recommendations for everybody in the same way. At the same time, you've been a champion in this about tailoring guidelines to patients, considering so many different things. Well, one of them should be cultural aspects, social aspects, particular interests that people may have based on their background.
Well, right after we're done, Enrique, I am going to search YouTube for Caballero salsa dancing and see what we can find.
I have avoided showing myself intentionally.
So I think the pathophysiology of diabetes is fascinating as it is manifested across different ethnic and racial groups. We do know that Pima Indians, some of the seminal studies on insulin resistance and beta cell dysfunction occurred in Pima Indians, studies that were funded by the NIH many years ago, a very insulin resistant group of patients. As we talked about, Asians may have greater beta cell decompensation, almost like the Asian beta cell can't tolerate the same degree of obesity that the European beta cell might. I think that is very, very interesting. And then we also know that in the African American community, there are differences in terms of a very commonly used metric for diabetes control quality, which is the hemoglobin A1C. What do we know about that?
Yeah, that's really very interesting, Silvio, and thanks for bringing that up, because that may have some practical implications. Even though there was some controversy at the beginning, I think that now we all agree that there may be different glycation processes when we compare different populations. And it turns out that in the Black population, the African American population, the glycation process is different enough to basically increase A1C levels when people have the same degree of glycemia when compared to other populations. So in general, A1C levels may be 0.3, maybe 0.4% higher in African Americans when compared to the white community, even though the degree of hyperglycemia may be the same. What we don't know is what the implication of this is. Is that glycation process also affecting the risk of complications? We don't know. So I think it's just for people to be aware that if there's a mismatch, for example, if I'm looking at my patient's glucose levels and the A1C seems to be a little higher, well, is that an African American patient? Maybe that's the reason.
But it does raise the possibility that we could be over-treating certain individuals, correct? If we're targeting lower hemoglobin A1C, and for the mean glycemia, they have a higher hemoglobin A1C, that could be potentially risky.
It could be, right? You may remember that in the Accord trial, for example, the risk of hypoglycemia was actually higher among African Americans. I still don't know why, to be honest, but I think this is something that we need to take into consideration about establishing targets. Although at the same time, what we don't know, as I said earlier, is what the implications are for complications, which is in the end, the reason why we try to control.
These thresholds that we've set forth for pre-diabetes and then diabetes at 6.5%, a 0.3, 0.4% difference is huge in terms of categorizing patients as having either normal glucose tolerance or pre-diabetes or diabetes.
That's correct.
Finally, let's talk about treatments of patients with diabetes, type 2 diabetes across various ethnic and racial groups. Have you, in your experience, found any specific pearls that we can take from our discussion? You know, I found that pioglitazone, which is a thiazolidinedione that has become less commonly prescribed because of adverse effects, in my practice is really effective in South Asians. So my patients from India and Pakistan seem to do very, very well. They have enormous insulin resistance, even though they don't have enormous obesity. They have a slight increase in BMI, as you alluded to before, but terrific insulin resistance demonstrated, whether you measure insulin levels or whether you look at fatty liver disease, and are predisposed to early coronary disease as well. And I find that they do very well, admittedly anecdotal, but very well with thiazolidinediones, which are now very cost effective because they're on generic formularies. Any stories like that that you can tell us from your practice?
Unfortunately, there are not a lot of studies that can truly guide us on using one medication over another in particular populations. For example, metformin, which obviously is first-line therapy across the world, works very well in some of these populations. I've been very fortunate to be a co-investigator in the diabetes prevention program. And in the DPP, we found that metformin works very well, perhaps even a little better in some of these minority populations. Although I would be careful because, these are small groups and we can't make any robust conclusions about that. As you well said, TZDs could work well because, as I said, insulin resistance is a background problem in many of these groups. You remember the studies by Tom Buchanan, remember with troglitazone, the first
Sure do.
TZD in the Hispanic community that worked very well. So I think that there may still be a role for those. And by the way, non-alcoholic fatty liver disease is very common in this population. So that could be another reason why we should think about some of these therapies.
There's a common cause of cirrhosis in that population as well.
Correct. So that's a major issue. But then about the newer medications. So for example, DPP-4 inhibitors, there are studies that show that may work particularly well in the East Asian population. With SGLT2 inhibitors, I was just reading recently a publication in Circulation by Alana Morris, who's a cardiologist, who did a subgroup analysis of the Emperor reduced and the DAPA heart failure study, showing that the cardiovascular outcomes may actually be better helped in African Americans and Asians than in the white population. Now, again, I don't want anybody to think, oh, okay, so that's what we need to do with everybody. These are subgroup analysis, but you're asking about data. Well, that's what we have. And then GLP-1 receptor agonists, because of obesity and all that, may also work well. I think at this point, what I would say is all medications seem to work equally well, perhaps better in some patients, but at least equally well, which I think is encouraging. We should follow guidelines and as we try to tailor that.
Certainly a lot more to learn. Well, Enrique, it looks like we are out of time. I want to thank you so much for chatting with me today about diabetes in minority groups. Any last words you'd like to leave our listeners with?
I would say that for us as healthcare professionals, again, thinking probably outside of our comfort zone and try to think about some of these social determinants of health. Everybody needs to discuss that with their teams and how to incorporate that routinely. But I want to finish also, Silvio, with something at a much higher level. I think that there is institutional responsibility. I work at the Brigham, and I'm very proud to say that the Brigham, as an example, is an institution that has taken this very seriously. And just, if I may, in a couple of minutes, I can tell you what happened recently. A group of investigators at the Brigham identified that patients that come for heart failure to the hospital, if they're African American or Hispanic, they are less likely to go to the cardiology service for their treatment. And they may go to the internal medicine or the general medicine department, whereas the white population is more likely to end up in the cardiology services. I mean, I think that's courage, that's brave to publish that and to recognize that academic institutions as big as the Brigham, we have room for improvement and we have the responsibility of seeing what's happening. So I would say for everybody that is listening, look at your practice, look at your institution. How are things happening? Are we providing equal opportunities to our patients? And if not, why is that happening? I'm sure that we all can identify strategies that can help us do what we want to do, and it's to help everybody. But let's not forget that there are some people that need an extra hand, and I think that's the right thing to do.
Absolutely. Thanks so much again for joining me today, Enrique.
My pleasure. Thank you for inviting me, Silvio.
And thanks for listening. I'm Dr. Silvio Inzucchi for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Silvio Inzucchi. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on type 2 diabetes.